I'm gonna share my screen now. Okay, doctors. Let's discuss today's topic. Right? Have you previously learned about cardiovascular risk assessment? Oh, this is the first time. Doctors, can you mute your mic? Yeah, I'm gonna share my screen now. Okay. Yeah, doctor. Let's learn it again. Okay, yeah. Okay. Yeah, doctor, I'm good. Thank you for asking. Yeah, let's start the session. Okay. So I'm gonna teach from the TG. Okay, you all know about the therapeutic guideline. Okay, let's start from. Yeah. So who can tell about the cardiovascular risk assessment? What is it? Why we should do the cardiovascular risk assessment? Why we should
මේ
assess
මෙන්ටලි
the.
හෙල්ත් පොඩ්ඩක් ඔෆ් කරලා කොහෙන් හරි සද්දයි කරත්තයක් වගේ. ඔයගොල්ලන් ගාව තියෙනවද රිමෝට් එක?
Hello,
අනේ පොඩ්ඩක්
doctor.
ඔෆ් කරන්න.
Hello, doctor. Can you mute your mic? I don't know whose mic is on yet. I'll mute it. Mm, if, okay, done. Okay. So, cardiovascular disease. Okay. So, why we should assess it? So, basically, cardiovascular risk assessment and the management in people without known cardiovascular disease, right? If we know if the patient has a cardiovascular disease, there's no need for screening, right? We can treat, right? Screening for the patient without cardiovascular risk, okay? Sorry, without cardiovascular disease, because we have to prevent, right? We have to prevent future cardiovascular disease. That's why we are going to screen these people, okay, these patients. So here, so risk estimation, usually we are predict the patient's chance of cardiovascular risk, cardiovascular event or some cardiovascular disease within 5 years. Okay, here we should assess the patients within future risk within the 5 years, right? For that, we are using a risk calculator. Okay, because the using the risk calculator is better than using a single parameter, right? For the Australia, we are using uh, cardiovascular risk assessment calculator. Okay, I will show it. So here also they are mentioned the same thing. Estimate the third paragraph. Estimate CVD mean atherosclerosis cardiovascular disease risk indicate the probability of the persons having cardiovascular event within a specific period of time. So, risk calculator take into account multiple interacting risk factors like age, sex, blood pressure, diabetic status to estimate person's ASCVD risk. This is superior to using a single risk factor for clinical decision making, okay, as it more accurately predict who will have a subsequent cardiovascular event. Okay, the recommendation in the topic are based on 2023 Australian Chronic Disease Prevention Alliance ACDPA. This is the risk calculator. Okay, we are using here. So, In the Australian cardiovascular risk calculator, the estimate person's risk over 5 years. Okay, we are estimating the risk of 5 years based on predict risk evaluation and stratifies risk into the following categories. Okay, there are three
Doctor,
types
can
of
you zoom
categories.
little bit if it is possible? Can you zoom this one?
Yeah, sure, doctor. Yeah, can you see it properly?
Yes, yes. Okay, thank you.
Yeah, sure. Okay, doctor. If you have any doubt, please unmute and tell, okay? Because today I'm using my iPad and I can't see the messages. Okay, because I'm using app, somehow I can't see the message. If I want to see the chat, I have to go back and check it again. So if you have anything, just unmute, okay? So here there are three types. This is very high yield. Okay, usually AMC more focusing on this because you everyone know, right? AMC is more into the screening, right? We have different guidelines for different diseases screening. This is one of this. Okay, cardiovascular risk assessment. So there are three types: high risk, intermediate risk, and low risk. Okay, I will explain one by one. Just for now, just listen, okay? So high risk mean like more than 10% of risk of cardiovascular event over 5 years. That mean patient can have cardiovascular event, some kind of cardiovascular disease within over 5 years. Is the risk is more than 10%. Intermediate risk means the 5 to 10% risk of the cardiovascular event over 5 years. Okay, within 5 years, 5 to 10% in intermediate risk. Low risk patient has a less than 5% of risk of cardiovascular event over 5 years, right? You should remember about these 5 years. We are estimate the risk within 5 years. Okay, you should remember this. Okay. So, but I'll show the cardiovascular. Sorry about that. Yeah, 1 minute. Yeah, this is the ACDPA, the risk assessment thing. Okay, in the TG also they have mentioned about 2022 CVD guideline and calculator. Okay, here we don't have to know about this calculator. Okay, this is the calculator. Okay, and in here in this website, this is the same thing, a Australian's cardiovascular risk Australian guideline. Okay, other than TG they have their own guideline as well. Okay, here also they are mentioning the same thing: high risk, intermediate risk, and low risk. Okay, this is like very colorful and very catchy. You can easily easily understand, right? This is very easy to understand. So this is the three types of risk: 10%, 5 to 10%, and less than 5%, low, intermediate, and high. Okay, so we have to identify, right? Identify the people who have cardiovascular risk. Like when we should start this risk assessment. Okay, the second thing you have to know about this is when we should start. Okay, here's the recommendation: for all people without known cardiovascular disease, assess CVD uh, risk from age 45 to 79 years. Okay, patients without known cardiovascular disease, we have to start this risk assessment from 45 to 79. Start from 45. Remember this word 45. Okay, you have to remember here 45. The next one is for people with diabetes without known cardiovascular disease. I already told, right? If we know the patient has the cardiovascular disease, we are not screening these patients, right? We have to treat them, right? In here, we screening to prevent cardiovascular event in the future. So that's what, okay, here the without non-cardiovascular risk. Here the second one, the people with diabetes, okay, people already have diabetes, but without non-cardiovascular disease. So access should be start from age 35 to 79 years old. So now we know two factors, right? For all people in Australia without any cardiovascular disease, we should start from 45. Okay. The second one you should remember, the people with diabetics but without non cardiovascular disease, we have to start from 35. For all 45, if the patient with diabetics 35. Okay, then the third thing you have to remember, for First Nation people without known cardiovascular disease. Okay, for First Nation people without known cardiovascular disease, uh, assess individual cardiovascular risk factors from age 18 to 29. Okay, I'll explain what this mean. And the second point they have mentioned, assess cardiovascular risk using Australian risk assessment from age 30. Okay,
Like
just remember, like,
all three are without cardiovascular, no? All three from age
yeah, doctor,
55 to
without
79 without and all.
yeah, doctor. Because if the patient have any disease, we have to treat it, right? Why we are going to screen? If the patient have any disease, we have to treat it, right? The
Yes,
screening
yes, yes.
doesn't help with the management, right? So if the
Yes,
patient
yes.
already have the disease, we have to treat it. In here, we are screening people to prevent future cardiovascular disease. So that's why we are screening here. In this patient without non cardiovascular risk. Remember these points, okay? Okay, I'll show TG. Okay, here. So here who we should assess. So 45 to 79 years, we all know without cardiovascular event. Okay, from 45. From 35, patient have diabetes. Okay, patient have diabetes. From 30, with First Nation people like Aboriginal people, we have to start the risk assessment from 30. Patient doesn't have to have like diabetics or anything. We have to start because they have very high risk factor for the future cardiovascular disease. Okay, so for all people, from 45, for people with diabetics 35, for First Nation people we have to start from 30. Okay, then you have to remember one more point. Okay, read this point. Around 75%, I think, hope you all can see my screen. uh, Around 75% of First Nation adults younger than 35 years have at least one risk factor for atherosclerosis cardiovascular disease. Although formal risk estimation using the Australian CVD risk calculator is only validated from 30 years of age, screen First Nation people for ASCVD risk factors from 18 of age. Screening in the young population should include the assessment of smoking status, blood pressure, blood glucose concentration, estimated glomerular filtration rate, serum lipid, urine albumin creatine ratio, familial cholesterolemia. Okay, I can't pronounce that word. Okay, yeah. So here you have to remember 4 points, okay? So main three categories here, okay? Like everyone without any cardiovascular disease, okay? Without. Okay, so all, okay, number 1 from 45, patients with diabetics 35, First Nation people from 30, okay? So below 30 we have to assess their individual risk factors estimation, okay? From 18, like smoking status, their blood pressure, like that, okay? Not the cardiovascular risk assessment. We have to assess their individual risk factors, okay? That's the here they are mentioned that thing, okay? So yeah, now we know when why we should assess this patient, and how we should assess from the cardiovascular risk assessment tool. Then who are the patients, who are the people we should assess, okay? So can anyone summarize the who need this cardiovascular risk estimation? Like 4 points, mainly these three categories, and next about the other First Nation from 18 years old. Who can like summarize? Who can revise it? Just give it a try. You, no one here to judge.
I can give it a try.
Yeah, sure, doctor. You can.
Like without any risk factors, we will start screening from 45 and
Yeah.
to 79 years. And with comorbidities like diabetes, we will start screening from 35.
Yeah.
And the First Nations peoples, we will start screening from 30 to 79 years.
Yeah.
So the First Nations peoples, whom we are screening from 30, but we are actually start screening from 18 years of age, but it was an individual screening, like we are screening her smoking status, blood pressure, blood glucose concentration, estimated glomerular filtration rate, familial hypercholesterolemia, serum lipids, and urine albumin creatinine ratio.
Yeah. Yeah, doctor. Yeah. You're absolutely correct. Yeah, thank you. Yeah, that's, yeah, okay. So that's finalized. Okay, now we know how, when, and who are the risk people. Okay, and okay, the same. Okay, next point. And 1 minute. And you have to remember one more point. Okay. So, what are the risk factors for atherosclerosis, cardiovascular disease, and their application in Australian CVD risk calculator? Okay, so here, so what are the risk factors? Here, risk factors that autonomically confer high risk. You should remember these 2 points, okay? So, if the patient presenting with familial familial hypercholesterolemia, and moderate to severe chronic kidney disease. Okay, moderate to severe chronic kidney disease, these patients automatically consider as high risk patients. Okay, remember this point. Please don't remember, okay? If the patient is presenting with familial hypercholesterolemia or moderate to severe chronic kidney disease, patient is automatically considered as high risk patients. Okay, yeah. Then risk factors considered in the initial risk calculator, as we previously discussed, the age, the male sex, smoking, elevated blood pressure, dyslipidemia, use of cardiovascular medicines like blood pressure lowering, lipid modifying within last 6 months, atrial fibrillation, low socioeconomic status, diabetes, like that. Okay. Then the next one, risk factors that can be used to reclassify risk. Okay. These are ethnicity. Okay. Remember this point. Consider reclassification to higher risk category for First Nation. We already discussed. They are high risk First Nation people. Then Pacific Islander people, or for people South Asian, Indian, Pakistani, Bangladesh, Sri Lankan, Nepal, Bhutanian, Maldives ethnicity, they are high risk for the high risk category. Okay, consider reclassification to a lower risk category for people in East Asian, Chinese, Japanese, Taiwan, or Mongolian ethnicity. Okay, I'll show a question. They are mainly in the immediacy, they have focus in here. Okay, just like remember some points. Okay, usually Asians and Australian First Nation people are like more prone to have cardiovascular disease, so they are high risk. And the patient with East Asian, usually South Asians are like more risk, but in the East Asian, like Chinese, remember Japanese, okay, Japanese, Taiwanese, Mongolian are lower risk category people. Okay, so then family history of premature cardiovascular disease. Family history, uh, mild chronic disease, severe mental illness, coronary artery calcium scoring. And I will explain this calcium scoring part in e-medicine question. Okay, then you will get a proper idea. For now, I will just read this. I know this is kind of weird. Coronary artery calcium scoring. A CT scan evaluating the amount of calcified plaque in the coronary arteries. Result may indicate greater or lesser extent of coronary atherosclerosis. Consider reclassification to a higher or lower risk category, respectively. Usually in the exam they are given which category, like that. Okay, I'll show the questions later. Okay, and these people, the risk factors not included in the risk calculate. Okay, you have to remember these as well. So chronic immune mediated inflammatory disorders like rheumatoid arthritis, COVID-19, preeclampsia, they are not risk factors in this calculator. Okay, poor nutrition, central obesity, like that, obstructive sleep apnea. Okay, like that. So the next thing is, now we know what are the risk factors. So the next thing is how we should manage these cardiovascular risk assessed patients. Okay, it's depending on the degree of the severity, like high risk, intermediate risk, or low risk. Okay, that's how we are treating them. Okay, so management according to the atherosclerotic cardiovascular risk estimate in here. So for the high risk patients, what we can do? Okay, let's start from the low risk, right? Okay, so low risk, what we can do? Low risk, like calculated as less than 5% risk of cardiovascular event over 5 years. So the low risk mean less than 5%. So lifestyle modification. Give general advice about diet and physical activity, including referral to the relevant services like accredited the practicing dietitians. We can refer them to the dietitian, exercise physiologist if appropriate. Okay, we, we can advise patient about the lifestyle modification. Then if patient needs some references like from dietitian or physiologist, like that. Okay, and provide advice, support, and if the patient is smoking, we can administer drug therapy for smoking cessation. Okay, and and the next one is drug therapy. Usually in here, not routine recommended. Okay, for low risk patients, the drug therapy is not routinely recommended. Okay, other than this smoking support, smoking drug therapy, we are not usually recommended any drug therapy like anti-lipid therapy or lipid lowering therapy or hypertensive drug therapy. We are not administer anything here. Okay, because the patient has the low risk. Discuss likely benefits and harms of drug therapy with patient and consider patient preference. Okay, so the intermediate risk, interme- sorry, so intermediate risk, what we can do. Now the TG is sometimes very hard to use. Okay, sorry for that. Here, the intermediate risk calculated as 5 to 10% risk of cardiovascular event over 5 years. So the risk is 5 to 10%. Here, what are the lifestyle modification here? So provide patient specific advice and support about diet, physical activity, including referral to the relevant services like dietitian, physiologists, like, okay, and they provide advice, support, and drug therapy for smoking. Okay, and then drug therapy. Here they are mainly drug therapy mean focusing of lipid lowering therapy and pressure lowering therapy. Okay, like antihypertensive drug therapy or lipid lowering therapy. So here, discuss likely benefits and harms of drug therapy with the patient and consider patient preference. And in here, you have to remember this: we can consider. Remember the word we can consider. Okay, here we can consider blood pressure lowering and lipid modifying therapy. Blood pressure lowering and lipid modifying therapy unless contraindicated or clinically inappropriate, withholding BP treatment. Okay, just remember here we can consider if the patient is not contraindicated, we can consider. But low risk, we are not recommended. Low risk, not recommended drug therapy, but intermediate risk, we are considering drug therapy. Okay. Then for the high risk patients, clinically determine high risk patient as more than 10% of the CVS risk assessment over the 5 years. In here, the lifestyle modifications are same. Okay. And here, you have to remember this point. Okay, lifestyle, the third point in lifestyle modification, lifestyle advice should be given in combination with blood pressure lowering and lipid modifying drug therapy. Okay, in here we must give blood pressure lowering therapy and lipid modifying therapy. In the low risk patient, we are not recommended blood pressure lowering and lipid lowering therapy. In the intermediate risk patient, we are just considering it. Okay, we are just considering with the individual risk. Okay, and in the high risk, here we must give lipid lowering and blood pressure lowering therapy. Okay, remember this point, you must give here until it's contraindication. Okay, I'll show 1 minute. Okay, I'll show the emergency part here. Okay, here the yellow part, high absolute cardiovascular risk more than 10%. We all know this is from emergency, okay, the yellow part, requires both blood pressure lowering and statin therapy regardless of blood pressure or cholesterol level. Remember this point, okay? I'll show the question as well. Regardless of blood pressure and cholesterol level, we have to give both blood pressure lowering and statin therapy, okay? Remember that. Okay, this is my note. I already told I'm making a set of notes, so I'll give an update tonight, okay? Because I have to make another one topic, then I'll give an update about it, okay? How you can take. Yeah. That is how we are treating, okay? And you have to remember one more thing. What do you think about antiplatelet therapy in atherosclerotic cardiovascular disease risk? Okay, here also they are mentioning in the last. Sorry.
So, doctor, if the cardiovascular risk is more than 10%, like if the
Yeah,
it is
doctor.
20%, so we will choose drugs, no? We will not gonna
Yeah,
choose any investigation in that case.
No, doctor. We are here. We are assessing the risk. Okay, here.
Yeah.
We are assessing the risk, and the main goal is to prevent future cardiovascular disease, right? If the patient is high risk, regardless of his blood pressure and the lipid level, we have to consider of giving lipid lowering therapy and blood pressure lowering therapy. Okay, I will show the question. Okay, in the images they are clearly mentioned. And here the last part in high risk patient, aspirin is not routinely recommended. Okay, remember this point as well. Okay, I will show here. Also, aspirin or other antiplatelet therapy is not recommended for the primary prevention of atherosclerosis cardiovascular disease. A summary of treatment recommendation according to the, yeah, this is another thing. So early trial of aspirin in primary prevention were done when statin and blood pressure lowering drug were less widely used. So the incremental benefits of aspirin is likely to be smaller in people who have already had their ACVD risk reduced by these drugs. Okay, so here usually the aspirin monotherapy is not routinely recommended. You have to remember that also. Yeah, other drug therapy and atherosclerotic cardiovascular disease risk. Here, annual influenza vaccination is recommended in all patients and associated with significant reduction in the risk of cardiovascular event. Okay, yeah, and we can give patients GLP-1 receptor agonist and SGLT2 inhibitor have shown the lower ACVD risk in patient with type 2. We all know diabetic treatments, right? So we can treat the diabetic patients to prevent the future cardiovascular diseases. Okay. Wait, I have to show something else here in here. Yeah. So, how often we should reassess the cardiovascular risk? Okay. Remember these points. If for First Nation people, reassess every year. Please remember this reassessing time period. Okay, how often? For First Nation people, reassess every year or opportunistically and at least every 2 years. Remember this annually. Okay, remember us annually. If the annual is not in the answer, you have to go with at least every 2 years. Okay, and for people At intermediate risk, like 5 to 10%, reassess after 2 years. Okay, remember, reassess after 2 years. For people at low risk, less than 5%, reassess after 5 years. Okay, low risk 5 years, intermediate is 2 years, and the First Nation people usually annually. Okay, and for people at high risk, like more than 10%, and the people in whom drug therapy has been started to manage cardiovascular risk, formal reassessment of risk using calculator is not required. Okay, that means for the high risk patient, we all know, right, we must start this drug therapy, the combined drug therapy, like lipid lowering and blood pressure lowering therapy. So in these patients, the patient is already in a in the treatment, right? In these patients, we are not do again and again the cardiovascular risk assessment. Okay, we are not doing assessment. Okay, remember this point. But other risk, intermediate and low risk, intermediate like 2 years, we have to reassess, we have to do this cardiovascular risk assessment tool again after 2 years. For low risk people, reassess after 5 years. But in, we all know, right, from First Nation people, we have to do it annually. Even after 14 years, after 14 years old also, we have to risk their individual risk, right? Because they are like more prone to have cardiovascular disease than other people. Okay, that's how doing it. In here, we are not in the high risk, we are not doing, because these patients are already starting the drugs, right? Because of the high risk, so we are not doing this risk assessment tool. Okay, yeah, that's all the thing you have to remember in the cardiovascular risk assessment. Yeah, that's all. Okay, let's do some emergency questions. Okay, doctors, give me 1 second.
Doctor, we don't give platelet routinely, no? We don't use it.
No, doctor, we are not recommended to use it. Okay, 1 minute. I'll open the emergency and I'll share my screen. Yeah. Okay, now you have to answer. Okay, I'm choosing your answers. Okay. I have to answer. Please unmute and tell. Okay, because I have to come back again and again, because yeah, I can't like see in the message. I don't know why. If someone know how to see the message while doing the Zoom session in iPad, I don't know, because of app or anything. I have no clue. Yeah, something need it. If someone have any idea, please help me. I'm not very good with the, this Zoom and everything. So here, okay, let's do our first question. 30-year-old Aboriginal, okay, you know what, Aboriginal, First Nation, man present to the general practice of clinic for a routine health check. He has no current symptoms and feels well. He has no significant medical history and does not take any regular medications. Okay? Yeah, sorry. He works as a teacher, is a lifetime non-smoker, drink alcohol occasionally on weekend, and exercise regularly. He has no family history of cardiovascular disease. On examination, he appears well with vital signs with normal limit, including a blood pressure of 118/76. His BMI is 24 and the cardiovascular examination is unremarkable. Investigation revealed total cholesterol 4.2 normal, HDL cholesterol 1.4, normal, more than 1 is normal. HDL mean good cholesterol, right? HbA1c 5.8, normal. Using Australian cardiovascular risk calculator, his 5-year absolute cardiovascular disease risk is calculated as 1%. Which one of the following is most appropriate interval for reassessing his cardiovascular disease risk? Okay, tell your answer. Okay, every 6 months.
Every year.
Every year.
Yeah,
Every
doctor.
year.
Yeah,
It's the first
okay.
question, man.
Yeah, okay, let's
Every
check.
year.
Yep. Yes, you're correct. Yeah. Now you know, right? Points what they're asking, right? Okay, so here we know. I'm reading the last part, the yellow one. First Nation people require annual CVS risk assessment from age 18 regardless of their calculated risk level. The Australian Cardiovascular Disease Risk Calculator recommended assessment every year as part of annual health check for First Nation people, or at least every 2 years, right? Okay. Yeah, you all know. If you have any problem, just ask. Okay, let's move to the next one. Okay. So, 42-year-old man present to the GP practice clinic for health check. 42. He has a history of IgA nephropathy diagnosed 5 years ago. His only regular medication is Ramipril. He does not identify as Aboriginal or Torres Strait Islander. He has no family history of cardiovascular disease. On examination, he appears well with vital signs within normal limit. His blood pressure is 128 by 82. Recent investigations show total cholesterol 5.8. Okay, HDL, total cholesterol increase, right? HDL 1.1, like in the margin, right? Marginally. Okay, estimated glomerulofiltration rate is 55. Urine albumin creatinine ratio is 2.5. Okay, normal. Which one of the following make this patient inappropriate for cardiovascular risk assessment using Australian CVD risk calculator? Less than 45 years, blood pressure less than 130 by 85, total cholesterol greater than 5.5, estimated GFR less than 60, urine albumin creatinine ratio greater than 2.5. What do you think, doctors?
It's A, na?
Okay, what about other doctors?
A as well.
Okay,
A.
okay, all agreed for A, right? Yep, okay. Yes, you are correct. Now you know points, right? I'm so happy. I'm so glad. Okay. So we all know, right? The patient, this person is 42, right? So he's not diabetic, or he's not a First Nation. In the question, they are clearly mentioned. So age less than 45, right? Okay, let's move to the next one. In here also they are mentioning the same thing. I think we don't have to read again and again. Okay, let's move to the next one. Okay, 65-year-old man present to the GP clinic for routine. Doctors, can you mute? Okay, GP clinic for a routine health review. He has treated hypertension and takes Perindopril. He smokes 5 to 10 cigarettes per day. Though he admits he previously smoked much more and drinks alcohol occasionally. He works as a banker. His father had MI at age 75 years. On examination, he appears well with pulse rate 72, BP 150 by 85, respiratory rate is 14, SpO2 99, temperature 36.7. Body mass index is 27. There are no abnormal findings on cardiovascular or respiratory examination. His fasting lipid profile shows the total cholesterol 5.4, marginal, high density lipoprotein HDL1, estimated absolute cardiovascular risk using Australian Cardiovascular Disease Risk Calculator is 12%. Over 5 years, 12% we all know, high risk, more than 10. Which one of following is next most appropriate? Yeah. Coronary artery calcium.
Share
Discuss statin therapy.
statin
Discuss
therapy.
statin therapy.
Discuss statin therapy.
All doctors agreed, right? What about other
Yeah,
doctors?
anti-BP.
Okay, so yeah, all agreed to this answer, right? So let's check. Yes, got the point clearly. Yes, nice. Yeah. Okay, so that's the point. Here, the patient with high cardiovascular risk, more than 10% over 5 years, should be offered statin therapy as a part of comprehensive risk education. Okay. Coronary artery calcium scoring can be considered when the cardiovascular risk is low or intermediate and treatment decisions are uncertain. Okay, remember this point as well. Okay, you all get the answer correctly. Should I need to read about the coronary artery calcium scoring also?
No.
Okay, let's move to the next. Okay, so next one is a 58-year-old woman, Taiwanese ethnicity, present to the GP clinic for routine health check. She has a medical history of rheumatoid arthritis and severe depression. Her regular medications are methotrexate, folic acid, and sertraline. She smokes 10 cigarettes per day and drinks alcohol occasionally. She works as a pharmacy assistant and lives with her partner. She has a family history of premature menopause in her mother and aunt. Her most recent EGFR was 72. On examination, she appeared well with pulse rate 74, blood pressure 130 by 80, respiratory 14, SpO2 99, temperature 36.7, body mass index 27. Recent blood tests show the total cholesterol 5.5 and HDL of 1.1. So you use the Australian Cardiovascular Risk Calculator to estimate her risk of a cardiovascular event in 5 years as 4%. You are considering whether this patient's risk profile should be reclassified and whether any further testing is needed. Which one of the following factors would reclassify this patient's cardiovascular risk as high? Remember that table? Reclassify table? What do you think,
Psychiatric
doctor?
comorbidity.
Yeah. So what do you think? What do you think about the answer?
I think it's a psychiatric comorbidity.
Okay. What about other doctors? What do you think? I'm not telling the answer. Okay. You have to try. What about other doctors? B. Okay. Ethnicity. What about other doctors? One answer is psychiatric comorbidities. Another one is her ethnicity. What about other doctors? Okay, some doctors have ethnicity. Okay, more. And there's another answer as renal functions. What do you think actually? Okay, so most doctors are agreed with B, right? Let's check the B. I'm not telling the answer. Okay.
Taiwanese, Japanese, these are low risk factors, no?
Yeah,
Yeah.
they are Mongolian.
The East Asian.
Mongolian, they are low risk group.
Yeah,
Yeah,
okay. I'm just
the
selecting
others
from
are the South
you
So
asked
Asian.
the
B
question.
maybe is not the answer.
Yeah,
Could be
okay. So what do you think? What should I select in here?
psychiatric comorbidity, severe
I
depression.
think maybe psychiatric comorbidity because maybe because Taiwanese, Mongolian, Japanese, Chinese are low risk group.
Mm-hmm.
We saw there, no?
Yeah.
Actually, I'm confused too.
Yeah, so yeah. What
Dr.
about
Sithara,
C?
maybe we'll revise the reclassification factors after.
Yeah, sure. I'll revise it again. Okay. Okay, so please finalize your answer. I'm gonna check it now.
My
Okay.
Okay, let's
final
check the
answer is
answer over
still
here. We can check it now, as most of the doctors are
Okay.
saying.
Okay,
It's
doctor.
okay.
What is your
Let's
answer?
clear
I'm gonna
their let's
Okay,
my
clear
I'm
their
final
gonna
is
doubt.
still psychiatric comorbidity.
Okay, let's go.
But it's not ethnicity. Yes, psychiatric
Yeah.
comorbidity.
You are correct. Yeah, doctor. That's how. Then you won't remember. Okay, and you
No,
won't
it's
forget
not
it.
B. It's sure.
Yeah, because
Yeah,
Taiwan, Mongolian, then Japanese.
and
They
it's
are
not
Chinese.
rare
Yeah,
now.
they are all
And it's
okay.
not rare
low
now
risk group.
because they said severe, moderate to severe.
Yeah. Okay, I'll show
Yes.
it again. Okay. TG is not user friendly. It's very hard to
Yeah,
use.
it's too busy.
Yeah. Okay, so here these are the reclassify risk factors. Okay, ethnicity.
Mm.
Consider reclassification high risk category for First Nation. We know First Nation, Maori or Pacific Islander people or people of South Asian, Indian, Pakistani, Bangladesh, Sri Lankan, Nepal, Bhutanese, Maldivian, those are high risk, right? But
Yeah.
East Asians like Mongolian, Taiwanese, Japanese, Chinese, like East are like less, okay? Less low risk
Lower
category.
risk group.
Yeah. So the next one is family history of premature cardiovascular disease. Okay. That defined as cardiovascular risk or stroke occurring in first degree female relative age less than 65 or first degree male relative age less than 55. Consider reclassification into a higher risk category. Then mild chronic kidney disease associated with the increased risk of CVD strongly consider reclassification into high risk category. And severe mental illness defined as a current or recent mental health condition requiring specialist treatment whether or not that treatment was received in last 5 years. Consider reclassification. Coronary artery calcium scoring. Here also, if the after CT scoring, if we can see the calcified plaque in the coronary artery, that's also considered as the reclassification to high risk. Okay. So these are the things. Okay, let's read the questions as well. Okay. So here her psychiatric comorbidity is the correct answer. Severe mental illness including the severe depression, is specifically included as the reclassification factor in the 2002 Australian guideline. We are still using that. Severe mental illness such as schizophrenia, bipolar, major depressive disorder are recognized to increase cardiovascular risk through multiple mechanisms including lifestyle, medicational effect, and biological pathways. Okay, so why not her renal function? Could be reclassified factor if she had chronic kidney disease. Okay, EGFR less than 45 or elevated, UACR more than 25 for males, or more than 35 for female. Remember these two factor. Okay, EGFR less than 45 and ACR criteria, for more than 25 in males, more than 35 in female. Just give it a read. Okay, however, this patient EGFR of 72 represent only mild reduction without evidence of proteinuria would not meet the criteria of reclassification. Ethnicity, we know. Family history, premature menopause is not included as reclassification. Okay, we already mentioned about the what we are not considering in there also. They have clearly mentioned about the clearly mentioned about it. Yeah. Yeah, premature the family history of premature. Oh, yeah, the same thing. Okay, we are done with this question. So the next one is 57-year-old man of Japanese ethnicity present to the GP clinic for routine checkup. 57, Japanese. He has a medical history of hypertension or hypercholesterolemia. His medications are perindopril and atorvastatin. He does not smoke and drink alcohol occasionally. On examination, he appears well with pulse rate 74, blood pressure 138 by 85, respiratory rate 14, SpO2 99, temperature 36.7, BMI 25, and the total cholesterol 5.2, high density lipoprotein 1.2, fasting glucose 4.4. All are normal, right? You use the Australian cardiovascular risk calculator and estimate his absolute risk of cardiovascular event in 5 years as 5%. Okay, so which one of following reclassification factor for that applies to the patient's cardiovascular risk assessment? So body mass index of 25 warrant consideration for reclassification. Male sex warrant consideration for reclassification. Age over 55 warrant consideration. Japanese ethnicity, age under 60. What do you think?
Japanese ethnicity warrants consideration.
Yeah, what about other doctors? Let's check the chat. Yeah, all agree to Japanese ethnicity. Alright, so Japanese ethnicity is correct. People of East Asian background, Chinese, Japanese, Korean, Taiwan, Mongolian, have a low baseline risk of cardiovascular disease compared to general Australian population. Okay, we know that. So let's move to the next question. So a 55-year-old man present to the GP clinic for cardiovascular risk assessment. He has type 2 diabetes diagnosed at 35 years with a recent HbA1c of 9.5. Okay, 55 diabetic. He has atrial fibrillation managed with amiodarone and apixaban. He smoked 15 cigarettes per day, has done so has done so for 30 years. He takes metformin and metoprolol. He works as a truck driver. On examination, he appears well. Pulse rate is 76 and irregular, II rate. Blood pressure 120 by 80. Height 170 centimeter. Weight 120 kilogram. On BMI is 41. Investigations reveal. Total cholesterol 5.2, HDL 1.1, LDL 3.4, triglyceride 1.5, estimated GFR 55, urinary ACR 2.5. Okay, so calculated 5-year cardiovascular risk is 17%. Which one of the following most appropriate next step in management? Lifestyle modification, commence aspirin, commence statin, commence
Yeah.
antihypertensive and statin, commence antihypertensive therapy only. What about other doctors?
Antihypertensive and statin therapy.
Yeah. Yep. Let's check the answer. Yeah, you're correct. Okay, so same thing. We all know, right? The answer, we don't have to explain it again. Okay, let's move to the next question. Okay, minute, doctors. Yeah, okay. So next one is 52 years woman present to the GP practice for the follow-up appointment. 52 women. 6 months ago, she had a coronary calcium score of 156 Auguston units performed due to a family history of early MI in her parents at age 48. She has no personal history of cardiovascular event. Since her last visit, she has been exercising regularly, trying to follow a Mediterranean diet, and has commenced rotorvastatin and perindopril. She asked about her future risk of stroke. On examination, she appears well with vital signs within normal limits. Her blood pressure is now 128 by 82. Recent blood tests show total cholesterol 4.2, LDL 2.1, HDL 1.4, triglyceride 1.5. Which one of the following factors make her ineligible for use of Australian cardiovascular risk calculator? Age less than 55, family history of early cardiovascular disease, coronary calcium score is more than 100, current antihypertensive therapy, current statin therapy. What do you think, doctors? You're gonna, okay, see. What about other doctors? Okay. Now, you're gonna learn another point, okay? Let's check the answer. Okay, you have to remember this, okay? I'm gonna explain. That's why I told you we will discuss about the coronary calcium score in the question, okay? So, the coronary calcium score is a CT-based measurement that quantifies the amount of calcium in the coronary arteries, reported in Auguston units. And so it serves as a direct marker of atherosclerotic burden. A score of 0 indicate no identifiable disease. 1 to 99 indicate mild disease. 100 to 399 indicate moderate disease. More than 400 indicate severe disease. A coronary calcium score more than 100 represent significant atherosclerotic burden and is considered evidence established cardiovascular disease. So, warranting aggressive risk factor modification including high dose statin therapy and aspirin regardless of traditional risk calculations. This makes use of risk calculation inappropriate in this case. So, the yellow part, a coronary calcium score more than 100 indicates the established atherosclerotic cardiovascular disease, making CVD risk calculator inappropriate, right? I already told if the patient already with cardiovascular disease, we are not doing screening, right? We have to treat it, right? Why we are doing screening, right? The same simple theory, okay? So, yeah. Yeah, the Australian CVD risk calculator is only valid for primary prevention in people without established cardiovascular disease. So, coronary calcium score in quantifying arterial calcification as a marker of atherosclerotic burden with a score more than indicate moderate to severe disease. Okay. If you want, just take a screenshot and remember 1 to 99 mild disease, like 100 to 399 moderate, more than 400 severe disease. Okay, like that. Yeah, you answered. These are the all questions from the CVS risk assessment in e-medicine. Yeah, you answered all correctly. Yeah, that's good actually. So now we are going to take a 10 minutes break and we will come back again in 10 minutes. Okay, now 9:08. Okay, 9:18. I'll come. Okay, so yes, let's do SNAP guideline. So what is SNAP guideline? Who can tell? Okay, I'm gonna share my screen. Yes, 1 minute. Yeah. So what is SNAP guideline? This is the SNAP guideline. Okay, what is it? I had to remember about SNAP guideline. So what do you think about SNAP guideline? SNAP mean in the word, okay? S means smoking, N mean nutrition, A mean alcohol, P mean physical activity, okay? Usually in SNAP guideline, they are mainly focusing of these major lifestyle risk factors in Australia. Okay, smoking, nutrition, alcohol, and physical activities. Okay, why they are like why they make this kind of guideline? What's the purpose? What's the purpose of this? Okay. So the purpose of the SNAP guideline is to prevent major chronic diseases by targeting the main behavioral risk factors to give standard practical 5-way framework for lifestyle counseling in general practice. Okay, I'll explain about these 5-way steps. Okay, and this can like guide the clinicians with the evidence-based intervention for smoking, diet, alcohol, and physical activity. Okay, to support coordinated long-term care through follow-up and referral pathways, to integrate preventive care into everyday general practice system and workflow. Okay, these are the like why we are using these some points why we are using this SNAP guideline. Okay, you have to remember the main thing is prevention. Okay, to prevent chronic diseases. Okay, so okay, this is a huge book, but you don't have to remember everything. Okay, so how we approach how we approach for the smoking, nutrition, alcohol, and physical activity. So prevention methods. Okay, you have to remember the 5 A's. Okay, how we should assess. First, for each of these criteria, we have to ask. We have to ask. That means identify the patient's risk factors. Okay, identify patient's risk factor. Then first ask. Then second one is we should assess. How we should assess level of risk factors and its relevance to the individual in terms of health, readiness to change, healthy literacy. Okay, we have to assess level, and we have to assess if the patient is ready to change. Patient is whether ready to change or not. We have to ask, assess, then we have to advise or agree. That means we have to provide written information about this risk prevention, and we have to brief advice and motivational interviewing. Remember this: brief advice and motivational interviewing. Okay, usually this motivational interviewing part is AMC's favorite one. Okay, one of favorite thing for AMC. Okay, remember this motivational interviewing. Then and in the advice or agree part, we have to the patient have negotiate goals and targets to reduce these risk factors. Okay, then fourth one is assist. How the doctor is assisting these patients. Okay, develop a risk factor management plan. We have to manage the plan that may include lifestyle, educational, or based on the individual risk. Okay, and support for self monitoring. Then fifth one is arrange. How we arrange it: referral to allied health service or community programs, phone information, counseling services, follow-ups, prevention and management of relapses. These are the main 5 A's you should remember. Okay, remember in here also the motivational interviewing and the brief advice are the AMC favorite part. Please remember. Okay, do you have any questions, any problems? Wait, I'll check the chat. Okay, no questions. If you have anything, just ask. Okay. Yeah, 1 minute. Yeah. Okay, so you know all 5 A's. Okay. Yeah, these are the things we have to assess. We have to use these 5 A's in each criteria. Okay, so it's smoking. How we should assess? We have to assess amount of smoked, dependence, readiness to change in the assess. So advice, how brief advice and motivational interviewing. Set a quiet date. Set a quiet date. Sorry. Okay, then the assist. Quit plan, consider pharmacotherapy, the arrange. Quit line and follow up visit. I'll explain about this. This is a telephone service in Australia. Okay, quit line. Yeah, I'll explain once doing the smoking cessation. And the next one is overweight. How we should assess overweight patient. We have to check BMI, waist circumference, and other cardiovascular risk factors. So, how we advise? Advise benefits of weight loss, set goals. You have to just remember advice about the benefits of the weight loss. Okay, usually we are giving the goals. Okay, it's depending on the BMI and waist circumference. Okay, I'll explain. And how we assess: provide tailored weight management plan. Okay, this is weight management plan. Then arrange telephone coaching, weight loss program, follow up visits. So poor diet. In here, how we should assess: Diet, we can ask about how the patient is taking his diet, about fruits, vegetables, their sugary drinks, fat and salt, the amount, and how often they are taking, like that. So advice anyway, set goals like for proportions of fruits and vegetables, reduce saturated fat, assist individualized diet plan. Okay, the diet plan is individualized, right, according to their risk factors and their behavior, like that. And they arrange the same thing. And the alcohol, so again we have to assess alcohol intake and his readiness to change. Then the advice, information and motivational interview, remember this. Then the assist, we can assist in here. We in the assist part we can give pharmacotherapy, right? Then arrange drug and alcohol services, okay, and the follow-up visit. So physical activity, we have to ask about the patient's amount, type, frequency of their physical activities, okay. And then same thing, set goals for minutes physical activities day and reducing the sedentary time. Okay, so physical activity prescription to assist. Arrange, we have to like exercise physiologist, we had to refer for the exercise physiologist, physiotherapist, or evaluated lifestyle modification. Okay, these are the 5 ways how we should assess the patient. Remember this motivational interviewing part. Okay, I'll explain why here. So what is motivational interviewing? That means help here, the motivate involves help the patient to identify areas for change. In here, we are helping the patient to identify areas that the patient should change, highlighting in discrepancies between present behavior and broader goals. Encourage the patient to examine the benefits they would experience from improving their lifestyle as nutrition, physical activities, and self management skills. Okay, asking the patient to compare potential outcomes if they do make changes versus if they do not. Okay, we can compare of the patient's outcomes. Okay, we can tell about these outcomes and we can compare about them and tell to the patient. Okay, asking the patient to identify any challenges, barriers, or negative aspect involved in the making improvement. Like if the patient has some money problem, like patient doesn't have good access to the access for the healthy food, like that we can ask. Okay, and helping the patient to determine specific and achievable solution to the challenges, barriers, and negative aspects involved in changes. Okay, establishing the patient's motivation and confidence to make the change. We can motivate, like we can explain about the benefits and we can compare about the benefits and everything. That here's like very motivative, right? The name also, you can see motivational interview, right? Remember this one. Okay, so okay, let's go one by one. So usually smoking, right? We know how we assist, like when should okay, and you have to remember this one. When you should start for screening about smoking. All people aged 10 or older. Remember this point, okay? All people aged 10 or old. When should start screening? When? Remember this point, okay? All people aged 10 or older. Okay. In here, you have to remember. And who are the higher risk of developing smoke related complications? We all know pregnant people, parent parent of babies and younger children, Aboriginal and Torres Strait Islander people, people with mental illness, other chemical dependencies, people with smoking related diseases like COPD, people with diabetes or cardiovascular risk factors, people from low socioeconomic groups. They are like high risk of developing complications. Okay. Yeah. So yeah, in here you have to remember this point. Okay. Then how we advise the patient. Okay. Usually how we remember, like how we treat the patient. Okay. Patient who smoke regardless of the amount should be offered brief advice to smoking. First of all, we have to counsel the patient, right? We have to advise the patient. In here usually like behavioral therapy, right? Counseling, everything is included in here, right? Advice and assist, right? So, smoking cessation is well established effective intervention within the primary care setting. Simple single consultation advice from a physician result in 1 to 3% of smoking quitting and not relapsing for 1 year. Okay, so here. And you have to remember one more thing, okay? So, uh, and you have to remember this one. You have to check the patient's nicotine dependence. How we check patient's nicotine dependence? Okay, you have to check these three. Number of minutes between wake into first cigarette. Okay, number of minutes between wake into first cigarette. Okay, if there is smoking within, here smoking within 30 minutes of waking and smoking more than 10 cigarettes per day and history of withdrawal symptoms in previous quitting attempts are all markers of nicotine dependence. Okay, so here if the patient need a cigarette, once the patient wake up within less than 30 minutes, and number of cigarettes per day, that's mean more than 10 cigarettes. And types of craving. Okay, if the patient has a craving or withdrawal symptoms experience in previous quitting attempts. Okay, remember these 3 points as well. 30 minutes, 10 cigarettes per day, and the withdrawal symptoms. So the patient has a craving for cigarette, craving. Okay, remember experience in previous quitting attempts. Okay. Remember this thing, nicotine dependence. Sometimes they can ask about this. Remember this, especially this 30 minutes part. Okay. Okay. So here, so how we treat these patients, like how we manage these patients. Who can tell? Okay, so here, first of all, we have to talk with the patient, and we should do the motivational interviewing, right? Motivational interview, brief explanation. These are all like behavioral therapy, right? Behavioral therapy. So we have to go with this first, okay? Behavioral therapy, because we have motivational interview. Okay, so then next one. So how we should treat next if it is fail or if it is not enough, how we should go with the treatment. Who can tell what is next one? Okay. So next one is pharmacotherapy, right? Pharmacotherapy. So usually here the pharmacotherapy may be considered in all patients smoking more than 10 cigarettes per day. In the absence of contraindications, pharmacotherapy should be offered to all motivation smokers with evidence of nicotine dependence. Okay. If the first we are doing the behavioral therapy, we have interviewing the patient. Then after that, we can consider about the pharmacotherapy. Okay. So here's the thing. You can read if you want, but They are not like mainly asking, but for your knowledge, just you can read. Okay, they are explaining everything here. Okay, next time jump to the pharmacotherapy. Okay, just listen carefully. If you want to make notes, just make it, because here it's like huge book. Okay, so pharmacotherapy. Usually, comprehensive here the tobacco use is most effectively treated with the comprehensive approach involved in behavioral support and pharmacotherapy. Okay, so pharmacotherapy, we have first administered the nicotine replacement therapy. Remember the nicotine replacement therapy. Remember it, okay? So how we can give nicotine in patients with the uh, for patient who need pharmacotherapy for to quit the smoke? How we can give? We can give it as a patch or gum like
Patch.
that, okay? Yeah, and sometimes can give us a gum as well, okay? Nicotine replacement therapy. In here, nicotine replacement therapy efficacy is like 60%, but if the patient with here, if the patient with life-threatening arrhythmia, pregnancy or lactation, or acute MIs, severe worsening angina, recent stroke or arrhythmia, we are not giving nicotine replacement therapy. Okay, it's contraindicated, right? It's contraindicated, right? So remember this point as well. Okay, what is the second line drug? First one is nicotine replacement therapy. Okay, if it is contraindicated, what we can use as next drug? Okay, so next one is varenicline. Okay, varenicline. Varenicline is the most effective monotherapy, more than doubling sustained abstinence rate at 6 months. Okay, follow up compared to placebo. In here, you have to remember there's a side effect, nausea. Okay, if the patient is taking varenicline, patient can have nausea. Okay, about 30% of users. For that, we for to prevent that, we can advise these patients to have this tablet with food. Okay, remember this. And although there have been concern about neuropsychiatric adverse effect, here we have nausea and the neuropsychiatric adverse effect with varenicline. Okay, varenicline. So, evidence from meta-analysis shows no increase in rates of suicidal event, depression or aggression, agitation compared to placebo. Okay, but they are not like we are not mainly consider it. Okay, we should remember nausea. For that, we are advising take it with the food. Okay, so this is first one. So, other than nicotine therapy, we can firstly consider varenicline. The second one, bupropion. Okay, bupropion. So, when we should give bupropion? Okay, remember like that. If the patient, okay, as example, if the patient is presented with depression and smoking dependent patient, okay, depression and smoking dependence, these kind of patients we can give bupropion. Okay, in here, bupropion when combined with behavioral therapy has been shown to be effective in patients who are dependent. And remember this depression point as well. Okay, I'll show once doing the question. Dependent, and it is contraindications with, remember this contraindication for bupropion. Sorry for my pronunciation, sometimes some words I can't pronounce properly. Okay. So if the patient has seizures, anorexia or bulimia, anorexia nervosa or bulimia nervosa, or central nervous system tumors, or MAO antidepressant treatment within 14 days. Okay, 14 days. We can't give this patient bupropion. Okay, so here bupropion is very like effective when given with the behavioral support. Okay, remember this. Yeah, so varenicline and bupropion other than nicotine therapy. Okay, now you all know what are the indications and contraindication. You have to remember this thoroughly. Okay, yeah, that is, and then you have to remember uh, this is what I told about the quit line. Okay, quit line medical service, caller service. Yeah. So follow up. If the patient after stopping the smoking, the patient have to follow up within 1 week, then after within 1 month. Okay, remember this. 1 week, then 1 month. Okay, that's all for smoking. Right, I'm gonna check the chat. If you have any problem, you can just tell me no, right? All clear with the smoking, right? Yeah. I know it's kind of hard to read everything, but this is the book you have to follow. Okay? Then overweight and obesity. They are usually asking so much questions from this obesity part. Okay? So, how we assess obesity patients? So, which parameter is more accurate in overweight and to assess in the overweight and obesity? Is it waist circumference or BMI? What do you think, doctors? What do you think about this weight circumference? So BMI, what is most like accurate? Who can tell? Just tell. Just two, BMI and waist circumference. If you can't tell, okay, you are telling BMI, right? Why BMI?
Waist circumference.
Yeah, it's actually weight circumference, doctors. Okay, remember this. This is the most accurate one. And you have to remember these points, okay? So, weight circumference. So, increased risk mean in the male patients more than 94 centimeter. If the female more than 80 centimeter. Remember this point, please remember. 94 in male has increased risk, and more than 80 centimeter in female has more increased risk. Okay, so who are the high risk? If the male patient has waist circumference more than 102, he is a higher risk patient. If the patient is a female patient and has more than 88 waist circumference, she is a higher risk for obesity. Okay, it's a higher risk for obesity. And here, the one more thing they have mentioned for children, waist to height ratio more than 0.5 may be used to guide consideration of the need for further assessment of CVS risk in children. Okay, I haven't see they're asking from this children part, but you have to remember in male, female, these parameters. Okay, then you have to remember BMI as well. Okay, both are important, but most accurate one is waist circumference. Okay. Now, so BMI is equal to body weight in kilograms divided by square height in meters. So you all know, right? What is BMI? So, how we classified BMI? You have to remember what is the normal one. Okay. So what is the normal one? BMI. The normal weight mean 18.5 to 24.9. Please remember these, okay? 18.5 to 24.9. This is normal. If the patient is less than 18.5, that means underweight. If the patient is 25 or greater, that means overweight. Okay, not obese, overweight. If 25 or greater. If the patient's BMI is 30 to 34.5, that means obesity class 1. Risk of morbidity is moderate, and the obese patient's BMI is 35 to 39.9, that means obesity 2 class 2, that have severe morbidities. Okay, remember. If the patient has BMI 40 or more than 40, that means obese class 3, very severe risk for the morbidities. Please remember these things. Normal, we all know, 18.5 to 24.9. Overweight, 25 to 29.9. Obese mean 30 to 34.5. Obese first class, obese second class is 35 to 39.9. Obese class 3 means 40 or greater. Okay, if you can't remember, just remember like this. Okay, 30 to 35, then 35 to 39, then 40. Remember like this. If sometimes it's hard to like remember this 0.9, right? Just reduce like 0.1 from each this side, then you will get a proper one, right? Okay, like that. Just remember like this: 25 to 30 overweight, 30 to 35 obese 1, 35 to 39 obese 2, then more than 40 it's obese 3. Okay, now this is how we should assess the obesity. Okay, so then first, how we advise patients to reduce obesity. Okay, we can advise patient to uh, like limited 2,500 kilojoules per daily energy deficit, and tailor program to dietary preferences of the individual. Okay, so this should be involve reduce saturated. Patient should reduce saturated fat and high sugar drinks. Size of the food proportions, everything should be reduced, right? To prevent to like reduce obesity. And we have to advise about approximately 300 minutes of moderate intensity activities and 150 minutes of vigorous activity. Okay, vigorous activity like high intensity activities and moderate intensity activities, 300 moderate 150 minutes high intensity activities. And then focus lifestyle for programs on parent, carer, and families if the patient if our patient is adolescent or child. Okay, if the patient is a children and has child obesity, have to focus a lifestyle program on parents, carers, and families, because we have to advise, right, them, because the children are smaller and they have no idea, right, how to control it. And acceptable approach in most situations for children who are overweight and obese. Okay, this the weight maintenance. Okay, advice to weight maintenance. The recommend lifestyle changes including reduce it includes reduce energy intake and sedentary behavior, and increase physical activities based on current Australian dietary and physical guideline. So, and you have to remember this one: Restrictive dieting is not recommended for children and adolescents. Restrictive dieting is not for children and adolescents. Okay. So what is the goal? Okay, in adults, to achieve a sustainable weight reduction. This is the goal I told in previously. Okay, you have to remember this goal. At least 1 to 4 kilogram per month, or 5 to 10% from initial body weight. This is the long term one, 5 to 10%. This is the short term, within month. Okay, 1 to 4 kilograms within month. Okay, just remember these points. Okay, you have to remember these points. Yeah. And the next one. Okay, we have to consider intensive interventions, like intensive one. Okay, because obesity is very high risk for the cardiovascular risk, right? So here we have to consider for intensive interventions for some categories. Who are they? Okay, just remember like this. Intensive interventions. I will explain about what is intensive interventions. Okay. Who, like, for whom we should consider intensive interventions? Patients' BMI is more than 30 or if the patient's BMI is more than 27 with comorbidities. So what is the category for the intensive interventions? Can someone tell? Who can tell? Okay, if the patient has BMI more than 30 or if the patient has BMI 27 with comorbidities. For these patients, we have to consider intensive interventions. Okay, for these patients, we have to think about very low energy diet for 18 to 16 weeks under medical supervision. Very low energy diet, VLED. Okay, remember we call this diet as VLED for 18 to 16 weeks. Very low energy diet for 18 to 16 weeks under medical supervisions. Okay, and if it is not enough, we have to consider about drug therapy. Okay, we have to consider about drug therapy. So what are these drugs? Are orlistat and phentermine. Orlistat for fat absorption. This can be considered as adjunct to lifestyle intervention. That means we can give a patient who already on VLED, yeah, like that. Okay, adjunct to the lifestyle intervention. And so this is good drug for the fat absorption, and phentermine is registered for short term use. Here the short term use. Okay, like 3 months. Phentermine for 3 months, but associated with range of side effects like hypertension, tachycardia, insomnia, and risk of tolerance. Okay, here the good drug is orlistat, fat absorptive drug. Okay, and sometimes you can if the sometimes here we can give anti-diabetic drugs for the obesity as well. Okay, I will show in a question. They are not mentioning in here, but sometimes in some questions they are mentioning about it as well. But mainly you have to remember VLED, that means very low energy diet for 8 to 16 weeks, and drug therapy like orlistat and phentermine. Okay, remember. And the next one is the last option is bariatric surgery, right? We all know the very last option is bariatric surgery for obesity. So, what are the indications for the bariatric surgery? Remember, if the patient's BMI is more than 40 or if the patient's BMI is 35 with comorbidities, here 40 or 35 with comorbidities, we have to go with bariatric surgery. Please remember this, okay? Here they are mentioning here bariatric surgery should be part of an overall clinical pathway for adult weight management that is delivered by multidisciplinary team, okay, and include planning for continuous follow-up. Although obesity rates are higher in rural area, especially service maybe not we don't need that, okay. Yeah, yeah. And for the follow-up, so weight should be reviewed after 2 weeks in order to determine it, okay. So we know, right, how we are treating the patients here, right? Can someone tell the what is the indications for the intensive interventions and bariatric surgery? Who can tell? You have to remember, okay? You must remember this. These are like very high yield for AMC in previous in each and every month they have asked about this bariatric surgery indications and how we treat, like it's a very high yield topic.
Yeah,
Recently they are like
for
Inter-
intensive intervention, BMI greater than 30 kilogram per meter square or BMI greater than 27 kilogram per meter square with comorbidities.
yeah,
Then for the bariatric surgery, BMI greater than 40 kilogram per meter squared or BMI greater than 35 with comorbidities that may improve with weight reduction.
yeah, doctor. That's how we are treating, okay? Yeah, it's depend on the BMI, right? Yeah. Further than that, this is the like main intervention, right? Main intervention. Yeah. Like that, okay? Step by step, we are like going for this. And follow up for 2 weeks. Do you have any questions? Wait, I'll check the chat. No, right? So, mm, sorry, yeah. I think I haven't done anything here, the same thing. And one more chart I want to show you. Wait. Here. Here the algorithm. Sorry. Okay, there's a chart. But this is from 2022. Okay. In here, they are mentioning it here as 37, but I have like marked it properly. Okay. Here, the same thing. Okay. Here the BMI is more than 30, the first part, BMI is more than 30, or BMI is more than 27 with comorbidities. Okay, remember this. Okay, so in here they are mentioning so what are the obesity related complications? Okay, you have here these are the obesity related complications. Medical complications: diabetes, cardiometabolic, NSH, sleep, PCO. So those are the okay. So and which psychological eating disorders, depression, low self-esteem, wait, I can't say stigmatization, physical osteoarthritis, personal hygiene, breathlessness. Okay, just remember some of these. Actually, they are given like with comorbidities like that. Okay. In the obesity related complications, if the patient is present with the obesity related complications here, Anyway, weight loss both without complications or with complications, both have, I already told, the target weight loss is what 1 to 4 kilogram within month or
Per
uh,
month.
yeah, month. Or what about other one? Minute, I will check it
I
again.
think is it 5 to 10%
Five to
body
yeah,
weight.
5 to 10% from the initial body weight. Okay. Yeah, initial body weight. Okay, that's why I am not like here. It's like kind of different because this is all guideline. I'm just showing because to get an idea about the algorithm. Okay, this is not the updated guideline. Okay, that's what I'm editing. Yeah. Okay, so here first, initial weight loss strategies we can use if the patient doesn't have comorbidities like low intensive, here LED mean low energy diet. Okay, low energy diet. VLED mean very low energy diet, like that. Okay, this is not like updated guidelines, so that's what I'm not like showing it properly. Okay, I'm not adding it. Yeah, just remember this thing. I think better that one, otherwise you are getting a wrong idea, right? Because everything is old in here. Just remember
Which
this
one should we
guideline.
follow, doctor? Like
This one, SNAP guideline,
SNAP
doc.
one, no?
Yeah, this one, SNAP guideline you should follow. This is also
Okay.
Australian guideline, but this is New South Wales guideline. This is 2022. That's what these are different. This one is 2025 guideline, the recent one. Okay, mostly we are using it. I already shared in the group. Okay, you can read it. Actually, it's better if we have a like flow chart, but yeah, currently we don't have any flow chart for this. Okay, but it's easy to remember, right? Yeah. Okay, so what about nutrition? Nutrition, like there's nothing like there's no specifically, wait, what is in the group? Yeah, thank you so much, doctor. Some doctor has commented in a group a positive thing. Yeah, thank you so much. Yeah, about the session. So what about nutrition? Okay, just listen carefully. You don't have to read each and everything. Okay, I'll explain what you have to remember. Okay, in the nutrition. So we have to assess anyway, right? I already mentioned the how often our patient is taking fruits, vegetables, like that. Okay. First, we have to assess it, right? Yeah, we have to assess it here. Like diet is, yeah, here the daily here. I'll show. The daily intake of fruits and vegetables is considered an important, yeah, diet. We all know, so we should assess it, right? So, example of a single serve fruits. Okay, usually fruit standard serve is approximately 150 gram. We should take. Okay, and vegetables standard serve is approximately 175 gram. You don't have to remember whole. Okay, that's why I was told, because this is not like very important. Okay, in here, so here advices, we can tell patient, we can encourage the patients to take more vegetables, fruits, and meats and other nuts and everything, reduce fat, like that. So those are the advice, and we have to advise a patient with vitamin supplementation. Yeah. Uh, but in here, vitamin supplementation is not established value in individual without signs or symptoms of deficiency or disorder. Okay, remember this part as well. Yeah, that's not in here. Just remember those small points. They are not asking from here. Yeah. So we all know, right, how to advise a patient about the nutrition. Yeah, you don't have to remember. Yeah, Not about follow up. Yeah, and here you have to remember this one. Okay, follow up should be reviewed every 2 to 3 months. Okay, this point. Okay, so next one is alcohol. Alcohol. Okay, let's. All patients aged 15 years and older should be asked about quantity and frequency of their alcohol intake. Okay, remember this. For the smoking, more than 10 years, we should assess. For here, more than 15 years, we should assess. Okay. And the tool here we are using is Audit C tool. Audit C tool. Okay, I'll show it from my note. Yeah, here. Yeah, here. So ask all more than 15 or 15 year about the drinking. Use Audit C score. So Audit C score mean this is a questionnaire. Okay, we don't have to remember about the question. Just remember there's a tool just about the questions. Okay, we are asking how often do you drink containing alcohol, how many standard drinks containing alcohol, and how often you have 6 or more drinks on single occasions. Remember how often do you have drink containing alcohol? Okay, how often? Then how many standard drinks containing alcohol you have on a typical day? And how often do you have 6 or more drinks on single occasion? This is the Audit C tool. Okay, so if this score is more than or equal to 4 in men and more than or equal to 3 in women are risk of alcohol. Okay, alcohol dependence risk. So in here, okay, this is also RSE from RSEGP, another alcohol dependence article there was. I took it from here. Okay, here the same thing: assessment, presenting problem, alcohol and other drug use, medical and psychiatric comorbidities, social circumstances. Okay, then we have to assess the severity of alcohol problem. Okay, if it is low to moderate, we can do the brief intervention. Okay, we can do the brief intervention. That mean motivational interview, those kind of thing. Okay, brief intervention. And if the severity is moderate to severe, patient require the withdrawal management. Okay, patient require the withdrawal management. Okay, just remember this as well. So, in brief intervention, effective in reducing alcohol use and related presenting problem. Okay, if the brief intervention are effective and it reduce the alcohol use, yes, then follow up and aftercare strategies. Okay, then we have to do only follow up. If it is not okay, effective brief intervention or motivational intervention is not useful, then again we have to go with the withdrawal management. I'll explain what is withdrawal management later. Okay, for now. Okay, if the withdrawal management is improve the patient's symptoms and everything, patient has reduced the intake of alcohol, then withdrawal intervention. Okay, then inpatient or outpatient. If there's patient does not require withdrawal management, intensive treatment in interventions. Okay, like psychological intervention. If patient does not require withdrawal treatment, if they require, that means if they need treatment, we have to give it inpatient or outpatient. Okay. And so, if the patient doesn't require withdrawal management, psychological interventions, pharmacotherapies, we can do. I'll show in the this thing in the SNAP guideline. Okay. So, what is the standard drinks per week and day? You have to remember in healthy adults. How many drinks Who knows? Standard drink. Okay, remember it.
Seems 2 to
Standard.
4.
Yeah, less usually per day, less than two single drinks. Okay, standard drinks.
Yes.
And yeah, for the week, I think eight.
10.
Yeah,
2 10.
10, right? Yeah, 10,
I
right?
think 10, yes, for a week.
Yeah, 10,
Mm.
right? Wait, we will find it here. Think it's somewhere here. Yeah. Okay. Like, and you have to remember one more thing about here naloxone, right? This is a huge topic. Wait, where is that thing? And alcohol have different topics. Okay, alcohol dependence. We are discussing here the dependence. Okay, and there's another topic, alcohol withdrawal. Okay, and the next, alcohol toxicity. I think you all know about these alcohol topics, right? We have to do it all because all are high yield. Yes, actually, I can't find it here. The treatment properly. I'll show it in here. Okay. This is the guideline I told about previously. Okay, let's go step by step. It's in here. So, here, psychosocial interventions such as motivational interviewing and cognitive behavioral therapies are most important and effective elements in management of alcohol dependence. So, the first thing first anyway in the psychiatric, like alcohol dependent, is like first we had to like counsel the patient, right? And motivational intervene, because in most of the exams they are asking about in the alcohol dependence, how we can like first initiate the treatment. So we have to go with motivational intervene. Okay, I'll send some recalls in the group. They're usually targeting on this. Okay. Yeah, then after that, similarly, mutual help of groups such as AA and cognitive behavioral therapy based on groups such as smart recovery map help. We don't have to remember this. Okay, just remember like first one is anyway motivational intervention and cognitive behavioral therapy. Then we can consider naltrexone. Okay, naltrexone here. Here, wait, where is the naltrexone? Yeah, medication to help to prevent relapses. Here, to prevent relapses, we are considering some medication. Or from all of that, naltrexone is the like main thing. Okay, because in emergency also they are mainly focusing on this one, naltrexone. So, relapses and prevention of the pharmacotherapy should be offered to all dependent patients following withdrawal management. Currently, there are three medications approved for the treatment of alcohol dependence: naltrexone, acamprosate, and disulfiram. Okay, these three. One, two, three. Just
Doctor, by any
remember.
chance we use benzodiazepines in alcohol withdrawal?
Yeah, withdrawal we can use. That's a different topic, doctor. Okay, because
Oh,
of alcohol
okay.
withdrawal, like delirium tremors can be seen, right? So for
Mm-hmm.
that we can use. I will explain it in delirium, because in delirium usually we are not giving benzodiazepine. Okay, we are not giving but in one scenario, like alcohol withdrawal delirium, that means delirium tremors, only scenario we are using benzodiazepine in delirium. Okay, usually benzodiazepine is not used in delirium. We have to differentiate delirium and acute psychotic event. For acute psychotic event we can give benzodiazepine, But for the delirium, we are not giving benzodiazepine, except in alcohol withdrawal delirium. We called it delirium tremens, and that occasion we have to give benzodiazepine. Okay, the
Okay. Okay. Thank you.
emergency point. Okay, I'll explain it in alcohol withdrawal and alcohol toxicity next part. Okay, that's a separated one. So here naltrexone, acamprostate, disulfiram. Usually they are asking in AMC, they are asking naltrexone and this one psychological intervention. Okay, these two they are mainly focusing, but it's okay. We will read others as well. So orally active opiate antagonists reduce the rate of relapses to heavy drinking to reduce of the reward associated with the drinking alcohol and by reducing craving. This is a active opioid. Okay, we are giving it to reduce the craving, alcohol craving. So acamprostate reduce the craving by helping reverse the overstimulated state resulting from neuroadaptation to alcohol. Okay, and the disulfiram is the oldest among these medication. Disulfiram acts as the deterrent to the drink because of the patient expect to experience severe negative reaction if they drink even small amount of alcohol. Okay, so just remember naltrexone and this one first anyway, cognitive behavioral therapy and motivational interview. Yeah. Yeah, I think for this is for alcohol and physical activity. Wait. Okay. Explain.
Dr. Sithara, please can I ask,
Yeah,
the pharmacotherapy is the second line, or are we doing it alongside with the psychosocial therapy?
usually we are giving first line as the motivational interviewing. Okay, motivational interviewing therapy or cognitive behavioral therapy. Usually, this is the first line to reduce the relapses and to reduce the craving for long term management. We can give naltrexone
Okay, so
like
this
that.
means that
Okay.
sometimes they can happen together.
Yeah. Yeah, you should like that. Okay, here this is a question. We'll do it, then you will understand. Okay, you can see the answer. Yeah, don't see the answer. Okay, but you can write. I don't know how to do this. Okay, oh no, this is another question, not this question. No, doctor, this is something else. I'll send in the group another question. Give me 1 second. I think I have. 1 minute. I think I have the question in my 1 minute, Dr. Silo. This one. Okay, doctors. Okay, I'll show the question, but yeah, I don't know in the app we can't zoom. Okay, I'll send this question in the group. Then I'll read and I'll type the answers. Mm, okay. Please check the group. Now I'm reading the question because here also I already marked the answers. Okay. So, 26-year-old man brought to the hospital via ambulance after motor vehicle accident in which he sustained mild injuries suitable for outpatient treatment. On further history, he admitted to having consumed significant amount of alcohol immediately before the accident. He admitted that his drinking habits have had a significant impact on his friendships, and that he is currently unemployed after being fired from his last job due to intoxication. He stated that he has always had difficult relationship with alcohol and has tried several times to quit, but with no success. His alcohol intake has been steadily increasing, and he now consumes approximately 15 standard drinks per day. He takes no other medication or recreational drug and otherwise well. Which one of the following is most appropriate pharmacological intervention to reduce his alcohol consumption? Acamprostate, diazepam, disulfiram, naloxone, naltrexone. What do you think? Type your answers in the chat, or you can just tell me. What is the answer? Please tell the answers, doctors.
Sorry, doctor, what was the options?
Yeah. Options are acamprostate, diazepam, disulfiram, naloxone, and naltrexone.
Naltrexone.
Yeah, naltrexone. Yeah, that's it. Usually, okay, I'll send the explanation as well in the chat. Yeah. So, here, okay, share my screen again. Yeah. Okay, here. This patient clearly has moderate to severe alcohol use disorder. He meet at least 5 of the DSM-5 criteria for alcohol use disorder. In patients who are currently continuous to drink, naltrexone is the most appropriate pharmacological intervention. In question, they are asking about the pharmacological intervention, right? So, naltrexone is long-acting opioid inhibitor and can decrease the sensation of the reward pathway associated with the alcohol, decreasing the patient's impulse to drink. That means decrease the craving, right? Yeah, caution should be taken in moderate to severe hepatic impairment. So why not acamprostate? Is effective maintaining abstinence, however, it is not as effective at helping patient quit. It is primarily effective at relieving symptoms of abstinences and withdrawal, and so is primarily used in patients currently abstaining from alcohol. There are also adherence issues due to the 3 times daily dosing and large physical size of tablet. Why not disulfiram? Maybe help patients maintain abstinence as it causing significant adverse effect when taken with alcohol. However, it is not indicated in patients who are currently drinking due to these adverse effects. Okay, so naltrexone is a long-acting opioid inhibitor and can decrease the sensation of the reward pathway associated with alcohol, decreasing the patient's impulse to drink. This is how they are asking the question. I just wanted to show how it's appear in the exam. Okay, this is how. In here, to reduce his alcohol consumption, what is the most appropriate pharmacological? Okay, we can give naltrexone like that. I'll send the other questions as well because in some questions they are asking about what is the initial one, and they are giving something about interventional in motivational motivational intervene. Yeah, now its time is like 10:26, right? My brain is kind of not working though. Yeah, yeah,
Yeah.
doctor. Yeah, yeah, for
Yeah.
the yeah, next one for the physical activities. I'll send some question in the group. Okay, physical activities. So we can ask about the assess while doing the assessment. We can ask for the type, frequency, duration, evaluate their sedentary time. Okay. So here the target is 10,000 steps per day. Okay, lower for older adults. So advice. Adults 18 to 16 years old, any activities is better than none. Okay, aim is 150 to 300 minutes moderate or 75 to 150 minute vigorous activities per week, like high intensity activities per week. Okay, and muscle in strength in 2 or more than days per week. Minimal prolonged sitting, break up sitting time, like that we can advise. But for children and adolescents, more than 60-minute moderate to vigorous per day and less than 2 hours per day screen time, like school age. Okay, yeah. And review 3 to 6 months. Okay, that's not more important. Yeah, like that. Yeah, doctors, SNAP guidelines is over, and we don't have time to do e-medicine, right? It's a huge topic, and the book is very lengthy, right? Yeah. Okay, so I think, and I'm hungry also. Yeah. Now the time is 10:28. And one doctor has asked about the note. Actually, doctor, like I'm making a cardiovascular module from each and every, because not some, many of doctors have like texted me and asked about make a note, like proper one to refer, because so much doctors are busy with their duties and everything. So I made a module. Yeah, it's like huge effort and like it's consume like more time, yeah, for that. So I have like take some charge, because it's like huge commitment, right? You all know, to read therapeutic guideline and other guideline and making, because I'm especially made in for those doctors who have asked me previously, because every day they are texting me and asking please make notes, please, and send them like that. So I'll give a today I finish all the notes for the cardiovascular system. uh, and I already shared my notes, like I used in my preparation and other all the therapeutic guideline notes in the file section. In I think I have shared in so many groups, because I know when I'm making a note while I'm doing my studying and everything, I really wanted to share with everyone. But for now it's like I'm actually taking my time and separating my schedules and everything to make this note, and because it's a huge commitment, right? So yeah, I will give an update about it tonight, because today I made the last topic, the snap guideline one as well. Yeah, I'll give an update, doctor, once it's like fully done. Like tonight I think I can give an update. Yeah, because I'm done with all the guidelines and everything. Yeah, and I'm doing anyway. I'm doing these fresh sessions till the like I really want to finish all the syllabus, because so much doctors have asked me. That's why I open this group and make this, yeah, Telegram one. Yeah, let's do the everyday topics, and yeah, I think we can finish before March, I think, but I'm not sure. What do you want to do as the next topics, like next module, respiratory or gin and ob? So what do you want? Actually, I'm giving priority to who are like daily participating in the group. What do you want, doctor? Neurology. Okay, what about other doctor? CNS. Yeah, okay, let's do it. Because my favorite one is neurology, actually. Yeah, doctor. Yeah, and there's a respiratory one as well. Yeah. I really want to be a neurologist someday, but not now. Yeah, one day I'll try because that's my dream. Yeah, actually. Yeah, then next one, so much doctors ask for neurology. So then I will do the neurology. Then after respiratory, okay? I'll make a separate note set for that one as well because some doctors have asked me like personally to make this note, and that's why I have like I have like invested so much time for that. You know how hard it's to read TJ every point and like other guidelines and adding e-medicine. I have added like e-medicine questions like 5 to 10 questions for each topics as well. It's a huge commitment. Sometimes I wake up in the 5 a.m. in the morning and I do the like note preparation and everything. Yeah, because some doctors really need this because they are like working and some has like children and they have like so much works and there's no time to do their to make do a note and like read all the guidelines. Yeah, I'll give update. Yeah, doctor. Yeah, and thank you so much for attending every day. It's encouraged me up so much actually. I really like to do sessions and no, I feel really good because you are like answering every questions properly, right? There's no doubt like so good because e-medicine is not like easy one, okay? E-medicine is like exam target, exam level one exam type of questions because sometimes they are directly taken from me medicine, so you are answering very well and that mean you understand the theory properly, right? That's all I want actually. Yeah, yeah, I'm not charging for these free theory sessions. I'm giving everything guidelines and everything, okay? But for that note I that's a huge commitment. Yeah, because I did it for like some amount of doctors who have asked. That's only, but this is all free. I'm not charging anything. Okay, every day I like to meet you and teach. My favorite thing is teaching. Yeah. Okay, so let's meet tomorrow. I think tomorrow we can start our neurology, right? Okay, let's do. Thank you so much, doctor. Yeah, thank you so much, doctors, for your lovely comments and everything. Each day I'm getting so much comments, like personal messages. I'm really grateful and so happy to hear that this is like starting of my like teaching journey for like AMC actually because yeah, I really like it. Yeah. Thank you so much, doctors. Yeah, okay, so I'm hungry. Now I have to go. Okay. So good night, doctors, and have a nice day. Okay, so bye bye.